if you're running out of room, if you've got them on 2 pressors and you're running out of room, you can give them a one-time dose of vasopressin to repolarize membranes, and it may allow your other pressors to work better. There are some people who are using vasopressin drips. I've not done that, but that's something you can look up and try if you're running out of room. Of course, I think at that point in time, they're sort of on the drain. I don't know if they'll see anyone come back from the vasopressin drip. That's just what I've seen. Levophed is your first line drug in sepsis. So if they've got septic shock, they need to be on Levophed. They also need a whole bunch of fluid. And that's why we do the central line and watch their CVP and we watch their MAP. That's what we're titrating for that. That's why I use that order set. Problems with pressors, rate control, they'll start getting AFib, they'll get ventricular irritability, they'll get PVC, trigeminy, bigeminy. Sometimes you'll see VTAC, avoid the VTAC, that's bad. That was a joke. Other tricks, dobutamine, especially in CHF, if they're in cardiogenic shock. Heart's going to pump harder, not faster. You're dealing with central pressure versus peripheral, so all of your other pressors are squeezing down periphery. Okay? And in fact, if you see someone's been on Levophed for a couple of days, they kind of mummify a little bit. Their extremities kind of get real dry and crispy, and they're not circulating out in the periphery. But dobutamine, you got to have adequate volume to work. Okay? So they can't be dry. So don't forget that. And you really got to titrate based on physical exam. Back in the old days, people had Swan-Ganz catheters in and you look at cardiac output, that's what you're titrating to. You're not really doing that much anymore. You don't really have good parameters to give your nurses, so you're not going to be writing your titration orders on dobutamine based on that. You're not going to write that. You're going to have to go look at the patient and make your own decisions. Okay? Based on physical exam. Hespan or Hetastarch or colloidals. There's a lot of debate. There's about 10 articles out right now. 5 of them say it's good, 5 of them say it's bad. Okay? There's no evidence of benefit in septic shock, and there's possible increased mortality in sepsis. So I would avoid it in those situations. But for other situations, it's probably reasonable if you're trying to get, especially on someone who's got low protein. If they're extravasating fluid, that's probably a good way to probably bring it back up. Don't forget saline. Don't forget blood. Rotating tourniquets for historical reasons. It's kind of an interesting thing to read about because you can control their preload that way. And like I said, I dare you to try and order that. That'd just be kind of fun to watch that happen. Xigris is pretty much out of favor. It increases mortality. I suggest you avoid using it. It's also like $12,000 for a course. Antipressors. Not a real Cardine's first-line agent, calcium channel blocker for out-of-control blood pressure. Oral is basically useless due to first-pass effect to the liver. Okay. IV, however, works very well. Nitro drips are also very good for blood pressure. They don't affect the rate. That's also really good for chest pain, especially if you've got someone with unstable angina that you can't seem to get their chest pain under control rather than just dumping a bunch of narcotics in them. Think about a nitro drip. Nitroprusside, I don't think anyone's really using that anymore, are they? Still. We haven't been using it, but
I think Dr. Miller, not yet, not right on.
it's a pain. You gotta put foil around it.